Today we're going to talk about the clinical evaluation of glomerular filtration rate. And this is important because glomerular filtration rate is a major function of the kidney, and when we have progressive renal disease, we see a progressive decrease in glomerular filtration rate. So as clinicians, we want to know what the GFR is in the animal that we're managing. There are several different ways that you can evaluate glomerular filtration rate. Historically, looking at the BUN and the creatinine on the biochemical profile is a way to evaluate GFR. We can also look at clearance techniques such as the creatinine clearance and the lohexol clearance. And finally, there are some more recent tests that have been developed, such as the cystatin C and the SDMA, that we'll talk about. Urea is synthesized in the liver from proteins, whether they be endogenous proteins in the body or exogenous proteins that come in through the diet. That is the source of the nitrogen for the synthesis of urea in the liver. Urea is not produced at a constant rate in the body because of this relationship with feeding. So although urea is widely distributed throughout total body water, it is not produced at a constant rate. It then is filtered by the kidney by glomerular filtration, and it does not secreted by the kidney tubules, but it does experience passive reabsorption in the tubules, which again is another factor which complicates its interpretation. So that if a patient is dehydrated and tubular fluid is moving more slowly in the kidney, there's more time for passive reabsorption of urea, which will have an effect on the urea concentration that can complicate our interpretation of the BUN. The non-renal factors that affect BUN relate primarily to its effects on protein intake, so that whenever we have a high protein meal, the BUN will go up a little bit. On the other hand, if the animal's anorexic, not eating at all, the BUN will go down a little bit. And these are non-renal variables that affect the BUN. Hemorrhage into the gastrointestinal tract is another important source of error because it's, if you will, a high protein meal for the bacteria in the gut. Finally, severe liver disease or portosystemic shunting are factors that can cause false reductions in the BUN. Creatinine is another molecule that has been used to evaluate glomerular filtration rate, and it is produced in the body every day at a very standard rate that is a function primarily of the muscular mass of the individual. Creatinine does not come in from the diet to any great extent. It's primarily just released from the muscle at a constant rate. So it's not affected by diet, as is BUN. Creatinine, likewise, is widely distributed throughout total body water, and the way it's handled by the kidney is very useful to us too, because it is completely filtered at the glomeruli, but it does not experience any reabsorption, nor does it experience any significant tubular secretion. So it's a very useful marker in that regard for evaluating glomerular filtration rate. Once we eliminate all non-renal variables from consideration, if we look at the usefulness of the BUN and the creatinine, their relationship to the percentage of functional nephrons in the kidney is what we call a rectangular hyperbola. And so as you can see from the graph, early on in the course of renal disease, we can have a fairly large decrease in the glomerular filtration rate, but we see very little change in the BUN or creatinine concentration, whereas later in renal disease, whenever the GFR is changing more rapidly, we then see a bigger change in the BUN and creatinine. So what this illustrates to us is that the BUN and creatinine, they are relatively insensitive tests of kidney function. It's important to realize that. However, if taking that into account, you can say that when you see an increase in the BUN or the creatinine, that 75% or more of the nephrons are non-functional. But it's also important to understand what you cannot say from the magnitude of the increase in the BUN and creatinine. You cannot differentiate pre-renal from post-renal disease. You cannot differentiate acute from chronic. You cannot differentiate reversible from irreversible, nor can you differentiate progressive from non-progressive disease. And these are limitations that must be kept in mind. Now, if we want to look at other tests of glomerular filtration rate, we can look at clearance tests. So the concept of clearance says that the clearance of any molecule is the volume of plasma that would need to be filtered at the glomeruli in 1 minute to account for the amount of that substance appearing in the urine per minute under steady state conditions. If you recall, creatinine is filtered by the kidneys and neither reabsorbed nor secreted, and therefore it is an ideal marker for glomerular filtration rate if we determine the clearance of creatinine. Likewise, we can use other compounds. When you do a creatinine clearance, you have to collect a urine sample. You need a urine sample, a blood sample, and the weight of the animal. When you do the lohexol clearance, this is determined by a pharmacokinetic procedure, and you do not need a urine sample. So that's very advantageous. So with the lohexol clearance, you need to collect 2 blood samples, but no urine sample, and then you can send that sample to the lab for the calculation of the lohexol clearance. Now I'd like to mention a few new tests of glomerular filtration rate. The first we'll mention is cystatin C, which is a low molecular weight cysteine inhibitor that is produced at a constant rate in the body because it's a product of a housekeeping gene. It is, again, not bound to plasma proteins, not metabolized. It is reabsorbed in the tubules, but it never is returned to the blood because the reabsorbed molecule is completely destroyed in the tubular cell, broken down. So it's as if it were not reabsorbed. Likewise, it's not secreted. So the cystatin C can be used as an indicator of GFR. The normal values in dogs are about 0.4 to 1.4 milligram per deciliter. The big issue with cystatin C, I believe, is that it is affected by feeding. So the concentration changes quite dramatically after feeding, and you really need to fast the animal for 12 hours before measuring it. So that is an important limitation of this test. There are a number of other factors with cystatin C where it's influenced by other disease states, inflammation, certain drugs, and so we really don't know enough about it yet to know if it's going to be a valuable test in dogs and cats as an indicator of GFR. So finally, I'd like to mention a relatively new test called the Symmetric dimethylarginine test, or the SDMA test. And the methylated arginines are post-translational methylation products of proteins that occur in the body. And there are several different types, the MMA, the ADMA, and the SDMA, depending on where the methylation occurs on the arginine residue on the protein. You'll notice that the ADMA is degraded to other products in the body and is not useful to us for kidney function, but the SDMA is eliminated almost entirely, over 90%, by the kidneys, and its concentration in blood is a good indicator of GFR. Now, if you recall with creatinine, creatinine is affected by the muscle mass of the individual. The good thing about the SDMA test, it is not affected by the muscle mass of the individual, and that is a big advantage. In a recent study that was done about SDMA in cats with chronic kidney disease, it was shown that the normal concentration was less than 14 micrograms per deciliter, and that in cats with chronic kidney disease, the SDMA increased on average about 17 months before the serum creatinine increased. So the SDMA test is a very sensitive test and is able to rule out kidney disease in animals quite nicely compared to the serum creatinine, as you can see from this table. It has very high sensitivity relative to creatinine. Lastly, this test, the SDMA test, was also evaluated in young dogs with progressive hereditary renal disease in this study, and it was shown that the SDMA, again, increased, in this case, on the average about a month or two before the serum creatinine increased. So the SDMA test is an exciting test that's become available that may help us diagnose kidney disease earlier than we previously were able to do.